Kia ora koutou. My name's Sarah and I'm the Head of Research at the Neurological Foundation, and it's my pleasure to welcome you to our online event tonight. I'd like to start with a saying that I have on my wall at work as a reminder of how research really works. E hara takutoa, e te toa takitahi engari he toa takitini. My strength is not as an individual, but as a collective. So let's get to the interesting stuff now and meet our speaker. Associate Professor Debbie Snell is a registered clinical and neuropsychologist working clinically at Te Whatu Ora Health NZ and also in the community, and is based in Christchurch. She's also at the University of Otago as an associate professor, and that is the branch of the University of Otago that is also based in Christchurch. She's the treasurer for the New Zealand College of Clinical Psychologists, again, the Canterbury branch, and she's been a member of the Neurological Foundation Council since February 2024. So I'm going to invite Debbie to now join us on screen. Welcome, Debbie. Thanks so much for joining us tonight. I'm really excited about this topic. It's one that's very interesting and we don't really hear much about it. So without much further ado, I'll invite you to share your slides and we'll dive into it.
Thanks, Sarah. I'm just going to share my slides and we'll be away.
Yep, that's great.
Okay. Well, kia ora koutou. Thanks so much, everyone, for being here this evening. It's really pleasing to see how many have turned up. I had visions of just one or two people, so I'm very excited to see so many people here. So tonight we're going to talk about something that isn't always getting a lot of attention, and this is when a spinal cord injury and a traumatic brain injury occur together. So as you can appreciate, these injuries can each be life-changing on their own, but when they occur together, recovery can be a lot more complex, affecting many parts of a person's life. So as Sarah said, I'm a clinical and neuropsychologist based in Christchurch. I'm really interested in rehabilitation outcomes, especially traumatic brain injury and concussion, and that's my passion. So I'm really happy to take any questions later on after the presentation about traumatic brain injury. So what we're going to cover tonight, we're first of all going to talk about what we mean by the double whammy and why it matters that the TBI is missed. We'll also talk about why it's so difficult to capture that traumatic brain injury. And then I'd like to tell you a little bit about our research, our SCITB study or SCI and TBI project, what we're doing to try and improve capturing the TBI in this area. But before I get into the talk proper, I just wanted to make some acknowledgements. So I just wanted to acknowledge the funders of our research, to the organisations that have supported our work, my co-investigators, Doctors Jen Dunn and Joe Nunnally, other collaborators as well. And especially want to acknowledge our participants who have given us their time generously and their insights. We couldn't do research without participants. And I also want to thank the Neurological Foundation for hosting me this evening. So what do we mean by the double whammy? So this is when a person sustains a spinal cord injury and a traumatic brain injury together at the same time in the same accident. And this is sometimes referred to as having a dual diagnosis, or in our case, we're calling it the double whammy. Importantly, when these injuries occur together, there can be potential for additive implications and impacts on recovery and rehabilitation. However, unfortunately, for lots of reasons that we'll talk about this evening, the TBI is often missed or overlooked. But what I want to do first of all is just unpack and talk about what we mean by spinal cord injury and traumatic brain injury. So let's start with spinal cord injury. This is an injury to any part of the spinal cord that affects the communication pathways between the brain and the body. So we're very much talking about the nerves that run along the spinal canal that are protected by the spinal vertebrae. We're not talking about the spinal vertebrae, the bony parts. We're talking about the cord that runs in between. So depending on where that injury is, that is the neurological level. It can change movement, sensation, or control of things like bladder and bowel function. And so common mechanisms, of course, we're talking about traumatic spinal cord injury. So we're talking about mechanisms like transport accidents, motor vehicle accidents, other road accidents, falls, sports, and assaults. So we're not talking here tonight about non-traumatic spinal cord injuries that are caused by other things such as infections or abscesses or tumours. So I mentioned the neurological level before, and this is considered to be the part of the spinal cord that is injured. So for example, when we talk about tetraplegia, we're referring to trauma to the cervical nerves, which are found in the top 7 vertebrae in the spine or neck. On the other hand, when we talk about paraplegia, we're talking about any trauma to the thoracic, lumbar, or sacral segments of the spinal cord. And these distinctions are very important when we start thinking about the likelihood of a traumatic brain injury occurring at the same time. And we'll touch on this from time to time through the presentation. A traumatic brain injury, on the other hand, it happens when the brain is jolted or hit hard enough to cause damage by some external force, for example, from a car crash or other road accident, a fall or a sports or assault impact. And as we appreciate and we know that the brain controls everything we think, feel, and do. So even very small changes can affect memory, attention, and emotions. TBIs can fall in the mild range of severity, and we call these concussions often, or in the moderate range or the severe range. So TBIs can be picked up by the person having been knocked out in the accident or having no memory of it. There can be TBI-related changes on brain scans, although these changes are often not seen if the TBI is in the milder end of the spectrum. So determining the severity of the TBI is often made by considering how long and if the person was knocked out, how long that memory gap was for events around the time of the accident. In addition, usual approaches to assessing for TBI severity involve tools like the Glasgow Coma Scale or the GCS, which you might have heard of. This is often applied by paramedics at the accident scene or by the ED teams. This tool is a tool that looks at level of consciousness to determine the severity of TBI. So the lower the score, the more severe the TBI. However, for the situation when someone sustains a spinal cord injury, this tool can be a little bit unreliable because it relies in part on motor responses, which can be affected by the spinal cord injury. So this makes the situation a wee bit more complicated. So what we can see emerging already are there are some overlaps between spinal cord injury and traumatic brain injury. There are certainly shared causes and mechanisms. So it's not surprising, really, if we think about it. If someone has an injury significant enough to break their spine or damage their spinal cord, they've also hit their head as well. But there can also be some neurological and symptom overlaps as well, and this can make sorting out if someone's with a spinal cord injury has also sustained a TBI very challenging. So on the next slide, we've got some common symptoms of both spinal cord injury and traumatic brain injury. So in the physical domain, there might be muscle stiffness or spasms, coordination problems, sensory loss, weakness, or pain. There's also fatigue, which is very common, and we're not talking about tiredness. We're talking about a really deep exhaustion that affects everything. There can also be sleep problems and slower speech, and all of this is part of the brain and the body trying to rewire and communicate again. Both spinal cord injuries and TBIs can cause cognitive difficulties. It can be harder to focus, take in information, and remember things. For example, it can be hard for a person with both spinal cord injury and TBI to remember what the physiotherapist said in the gym yesterday and which strategies the occupational therapist has been working on. There can be other similar impacts as well, such as changes in mood, anxiety, low energy. Sometimes family and friends notice irritability, or the person is more tearful, or just generally not quite themselves. So when both a spinal cord injury and a TBI occur together, these symptoms can all be amplified, as you can imagine. And it does make the picture very confusing when trying to work out what's associated with this spinal cord injury and what actually might be reflecting the additional injuries, such as the traumatic brain injury. So the dual diagnosis, or in our case, we're talking about the double whammy, when the TBI co-occurs with the spinal cord injury, is more common than a lot of people think. While it can be difficult to work out just how common having a spinal cord injury and a TBI together is, in some studies this has been as many as 75% of study samples, so that's quite a lot. Research, however, disappointingly also shows that the TBI is missed in up to half of samples of people with spinal cord injury where there's been at least a mild TBI. So that is the really concerning part. And like the non-spinal cord injury population, the research is fairly consistent in estimating that most co-occurring TBIs fall in the mild range of severity, which we also call concussion. Up to 82% of TBIs occurring with a spinal cord injury are considered to be concussion or mild TBI. And finally, there is some research that suggests that a TBI might be more likely if the injury mechanism was a motor vehicle accident, so when we're thinking about the forces involved in a motor vehicle accident, or if the person has broken their neck, which is close to their head. However, relying on these aspects is a risky business, and we'll come to that again throughout the presentation, where relying on those kind of criteria may miss TBI. So why does it matter that the TBI is missed? Well, firstly, when a TBI is not identified, there can be huge impacts on recovery and progress in rehabilitation. As well, TBI symptoms can actually interfere with progress. The more severe the TBI, the more significant are the consequences. But even TBI in the mild range can play havoc with progress, including staying longer in hospital, making less or slower progress, and even lower rates of return to work and independence. And sort of unfortunately, really, rather than being linked to the TBI, these symptoms can often be mistaken for signs the person isn't engaging in their rehabilitation sessions, they're maybe not trying hard enough, they're not motivated, or they're just having problems with adjustment and stress. In addition, TBI symptoms such as personality changes are often noticed first by family and whānau. And in our earlier work, they told us that they recognised their family member as different in some way, above and beyond the spinal cord injury, but they don't know where to go to for help to understand these changes. And most importantly as well, if the TBI is not recognised and documented, there can be problems with access to TBI-related support later on when that support is needed. We'll come back to that on the next slide. So while more severe TBIs have larger impacts in general, as I mentioned, the addition of the TBI in general can result in longer stays in hospital, less gains in rehab, greater dependency at discharge, difficulties adjusting back into life after hospital, higher costs for everyone, including lower rates of return to productivity such as work and study. But also missing the TBI is a missed opportunity, especially for rehabilitation, where the TBI impacts can be managed to reduce the impact of the TBI on outcomes and recovery. So, for example, the spinal rehab team can tailor the environment to manage sensory overload, such as making sure the person is in a quieter part of the ward, keeping lighting down, for example, managing visitors, scheduling rests to manage fatigue, providing written information and other memory cues to help compensate for memory problems, getting the psychologist involved to work on strategies to manage emotions, and in particular, not just assuming that because the person's emotions are all over the place, this is because they're not coping. And after discharge, as I mentioned on the previous slide, when that TBI is picked up and documented, the community teams in ACC can factor this into their planning of assessment and needs. So that's a very important point. So what are the challenges and barriers? So why is it so difficult to capture that traumatic brain injury? It sounds like it really should be straightforward, yet it isn't. Most of the time when the TBI is in the severe range, it is easily noticed, although this isn't always the case, and it isn't always the case when the TBI is in the mild or moderate range. Part of the problem is that there are no reliable guidelines to follow. There is no clear agreement about how best to capture that traumatic brain injury, or even when screening for TBI is best undertaken. Doing this too early and the picture is complicated by acute medical problems, and TBI symptoms can be easily overlooked. But because of the overlaps we've already been talking about, relying on symptoms the person reports alone without considering other information, maybe even just thinking about the mechanism of the accident or even the level of the spinal cord injury, can mean that the TBI is difficult to tease apart from that spinal cord injury. In New Zealand, we have a well-established pathway for spinal care, and this is quite important. After a suspected significant spinal cord injury, the person is taken from the accident scene to the nearest major hospital that is equipped for trauma care, and this is for stabilisation before that person is transferred to a spinal rehabilitation centre. So we have two of these in New Zealand. We have one in Auckland at Middlemore, or at Burwood and Christchurch. So where a person goes largely depends on where they live in New Zealand. but this means that there are stays in ICU or another hospital first. And for some, it can even take a few weeks before they finally are transferred or admitted for rehabilitation. So this is the big question, really. So when in this pathway should TBI be considered? Should it be considered in the emergency department or in the ICU? Or should we be waiting until they get to the rehabilitation centre? Certainly, competing early priorities mean the focus is often on the more severe TBI, spinal cord injury, as you can imagine. After an accident, the first focus is usually on stabilising that injury, and this means brain injury can be missed at first, especially if it's mild. But it's also normal for some symptoms to show up weeks later as acute medical issues are stabilised and the person is starting to get back into their usual activities, things like reading, using their devices, remembering their timetable, and so on. And this is often when signs of TBI can start becoming more apparent. So what I want to do is take you to the next part of our talk and talk about what we've been doing in our research, our SCIPB project. But I want to pause there just to make sure that there aren't any questions coming through about the first part of the talk.
Thanks so much for the first part of your talk, Debbie. I guess one of the things that came through quite strongly is that it seems that a spinal cord injury is easier to diagnose than a traumatic brain injury, particularly when they're mild. And why is that?
I think it's much more clear in terms of the symptoms and signs that a spinal cord injury has occurred. Sometimes the signs and symptoms of a TBI can be quite subtle and easily mistaken for other things. So I think they're very easily overlooked symptoms.
And what factors would contribute to the prolonged concussion symptoms, making it longer for some people to recover than others?
So that's a really good question, and it's quite a complicated one, because I guess it really kind of matters what sort of head has been hit rather than the nature of the injury. So whether that person has had previous concussions, whether they've had a past or current mental health history that makes them a wee bit more vulnerable to becoming depressed or more anxious after their concussion. Sometimes it can depend on age. Older people can sometimes take longer than younger people. So there are a lot of factors that can contribute to length of time that somebody takes to recover from concussion. And quite often as time goes on and things like stress come over the top and kind of impact on a person's managing and coping as they try and return to work or maybe fail in that process or have to start again, that can become very stressful, and those psychological factors can feed in into the picture and make things more complicated as well and just prolong that recovery.
One of the questions that we get asked quite often is, does traumatic brain injury actually increase the risk of developing dementia later in life? Do you have an opinion on that?
I do have an opinion on that. We get asked that a lot in our concussion services, and people are really concerned if they've had more than one concussion, if they might be more at risk for developing a degenerative condition like a dementia later in life. And I think there is some evidence that severe traumatic brain injury can increase a person's risk. And certainly more recent traumatic brain injury amongst our older population can increase the risk that there is a development of a dementia diagnosis. But there's this thing called reverse causality, which I think we see quite a lot in our clinics amongst older people, is there might have been some subtle or milder signs of dementia or some mild cognitive impairment emerging before the concussion might have increased their risk for having a fall and hitting their head. And so when they present to a concussion service, this triggers off a raft of assessments, ultimately resulting in a dementia diagnosis. And we couldn't really say for sure that the concussion caused that dementia diagnosis, but it certainly happens afterwards. And so sometimes those things can become conflated and mixed up. But certainly there is some evidence that a more severe injury can increase risk for developing a dementia later in life.
Yeah, I guess that's a really good point, actually, that sometimes falls can be a sign of dementia and you don't really realise it until you have those further assessments.
I think that's right, and I think there are some other conditions as well, like motor neurone disease or something like that, where there are some early incoordination signs increasing that person's risk for falling, hitting their head, and then they have assessments and they maybe go and see a neurologist, and then that diagnosis follows. So it's not that there's a causal link between those conditions, but it's certainly the concussion has facilitated more assessments and that diagnosis, if that makes sense.
Yeah. So we've got a question about that unconscious period or traffic accidents that are the flags for possible TBIs. So do you find that TBIs normally get caught in those situations, or are they still being missed in traffic accidents?
I think there's still a risk that they are missed, especially if the period of loss of consciousness wasn't for very long. And sometimes I'm going to come back to this when we talk about some of the research we've been doing in this area. But sometimes things get documented early on, but they don't travel with the person. And so the information kind of drops out of the record, or it's not clear how long that person was unconscious for. When someone is unconscious for a long time, it's almost never missed. So the TBI is almost always picked up when someone is unconscious for a long time, if that makes sense. It's really when the TBI is in that milder end of the spectrum that it becomes much more murky.
So why are those TBIs missed if people are not unconscious or they're not in an accident where they're known to have hit their head? Why do those TBIs get missed?
I think it's because of the kind of confusion between what could be spinal cord injury and what could be traumatic brain injury. I'm going to come to this in the second half of the talk in a little bit more detail as well. But there is that overlap between those symptoms and signs, which make it quite difficult to tease out what goes with what. And so spinal cord injuries can cause confusion and cognitive impairments as well. And so that can be quite difficult to tease out from the cognitive impairments that are caused by a traumatic brain injury, for instance. So it certainly can be quite complicated and quite murky as a picture. And whilst most people have brain scans when they're admitted into hospital after a spinal cord injury just to check for TBI, if that TBI is in the milder end of the range, often there are no signs on imaging or brain scans that can really help identify TBI. So it does make it quite complicated.
Is there a certain length of time unconscious that flags a TBI?
Well, certainly the length of time that somebody is unconscious indicates the severity of the injury. So if someone's unconscious for sort of like 20 minutes or so, we would still classify that as a mild traumatic brain injury, even though that sounds like a long time. But, I think sometimes when someone has an accident, it can take time for the paramedics and the accident and services to reach the person. So sometimes it's not clear that they've been unconscious over that period of time before the emergency services arrive. So if they've got witnesses, that can be helpful if somebody's on the scene early, but sometimes that person might be on their own and it becomes very unclear then that they've been unconscious at all. They might be confused when the emergency services arrive, but maybe because of other factors, it may not necessarily be attributed to the TBI.
Well, we might finish up, but with one more complex question, actually. So how might trauma to the cervical spine impact blood flow, lymphatic drainage, or cerebrospinal fluid movement?
Oh my goodness.
Just the connection between impacting those and causing symptoms in the brain.
I think there's definitely some shared mechanisms around neuroinflammation and things like that that can cause some of those symptoms, but this is out of my scope really. I'm not really a medical doctor or able to kind of comment on some of those more specific links, unfortunately.
I guess a simple way to put it would be, do you see TBI symptoms in people that don't actually have TBI if they've got a spinal cord injury?
Absolutely. Yeah, that is absolutely the situation. The symptoms are very much overlap and can be easily missed or mistaken for signs of TBI when they're actually related to the spinal cord injury and vice versa. So it is murky and it is difficult to tease that out.
Yeah, and I guess all that nasty stuff going around in the blood and the cerebrospinal fluid and the lymphatic system after an injury. So I will now let you move on to the second half of your talk. And if there's any further questions, just keep entering them into the Q&A and we'll address them at the end of the session. Thanks, Debbie.
Oh, okay. So now I want to tell you a little bit about what we've been doing in our research project, the SCIPB study. And so the first thing we wanted to do with the study is to look at what the research literature told us about how best to capture that traumatic brain injury when it co-occurs with a spinal cord injury. So the first thing we did was we undertook a scoping review to look at international research studies, considering how best to identify that TBI. So a scoping review is really just a way to take a really broad look at what is out there to map what is known. So our question for the review was, what is the evidence for TBI screening amongst persons with traumatic spinal cord injury? For example, we were most interested in what's the best timing and what are the most reliable ways to screen for TBI. So what are we being told from their research evidence? So we looked at studies from a range of different databases. We looked at studies from 2000 and, well, I think actually we started in 1990 right through to 2025, and we only found 11 studies. So that's not a lot of research, which is really surprising. We did find studies from a range of different countries, which including New Zealand, which is good to see. But of course, that also contributes to some of the murkiness, because all of these different countries have different processes and pathways for people coming from an accident scene into hospital into rehabilitation. So it means that it's quite difficult to determine at which point in that pathway we really want to be screening for TBI. So what do we find? So the biggest challenges across studies were pretty consistent. So most of the study authors kind of referred to this kind of inconsistent use of and documentation indicators of TBI. So this included trouble finding references to TBI in clinical notes. So, and I think this is really about the focus on the more severe injury at that stage. All of the different studies also use different ways of defining and identifying the traumatic brain injury with no clear consensus, which again just adds to that confusion about what we're trying to find. All of the studies noted that there were difficulties determining what is associated with the TBI and what is the spinal cord injury, noting that this is really difficult to tease out, and we've just been talking about that already. And unfortunately, not yet anyway, there is no easy test for traumatic brain injury, which would of course make life a lot easier. Most of the studies felt that TBI was more reliably captured if that TBI was severe. Some studies felt that TBI was more likely if the accident was a motor vehicle accident, so thinking about those forces involved in a motor vehicle accident, or if the person had a cervical spinal cord injury, that is a broken neck. However, conversely, the studies also noted that actually that's a bit risky to rely on those factors, because TBIs were missed when the TBI was in the mild and moderate range. The mechanism wasn't a transport-related mechanism, or the spinal cord injury level was below the neck. So this means really just looking at that TBI based on the level of the spinal cord injury or type of accident is risky. Unfortunately, we didn't find any guidance at all about the best time to screen for a TBI in the spinal cord injury pathway in the literature we looked at. We'll come back to that in a minute when we moved on to other parts of the study. In terms of looking at TBI symptoms, a small number of studies used self-reported TBI symptoms with questionnaires, but all of those studies recognise that self-report by itself is not enough. And we'll come back to this point again too, because it's really getting to the heart of that confusing picture between spinal cord injury and TBI symptoms. And also, finally, only one study out of all of those studies that we looked at considered outcomes for children sustaining spinal cord injury and traumatic brain injury. So there's a really huge gap there around what's happening for children in these outcomes. So then what we did for the next part of the study is we went to the spinal rehab teams and people with spinal cord injury and TBI to see what they thought. So we undertook a series of consultation meetings with the Auckland and Christchurch spinal rehab teams. We talked to the physiotherapists at Burwood, the occupational therapists at both Auckland and Christchurch, and the medical teams. And what we wanted to do is we wanted to find out what the spinal teams felt would improve the consistency of capturing that co-occurring TBI, and what would actually work in their services. There's no point coming up with recommendations if the services don't think that they will work. So all of the groups we spoke to agreed that capturing the TBI was important but really challenging, and that it could be better undertaken. There were 3 themes. So the first theme was being able to determine what symptoms could be TBI related, and this was raised by everyone that we spoke to. And this again reflected those concerns about the difficulty determining if symptoms were associated with that TBI or other factors, including the spinal cord injury. And so one of the physiotherapists said, you know, because we often end up having this discussion in team meetings where this may be a TBI, but then a series of obstacles and barriers come up. Maybe it's medication, maybe it's because they're away from home, maybe it's stress, and then it just gets too hard. Helpfully, our consultation meetings touched on this theme around the timing of TBI screening, and the spinal teams had some very helpful thoughts on best time for looking at the TBI. They felt that the best time was the point of admission into the rehabilitation centre, especially the goal setting phase was the optimal time to consider TBI screening. And they also felt the occupational therapists would be the best team members to start that process off. And the reason for those thoughts were that they just felt there were too many confounding factors when patients were still in ICU or the first hospital before coming to rehab. One of the doctors made a comment that the best time is when they're starting in rehab. And our third theme, which was a little bit unsurprising, unexpected, I should say, and surprising, was related to the concerns about raising a potential TBI diagnosis. And this included confidence in making that diagnosis and worries about the stigma of labels. And this wasn't something that we were expecting to find. So, for example, one of the physios said, I just don't feel well enough trained to start raising TBI concerns. And one of the occupational therapists and one of the physios said, we just don't want them to get pigeonholed or labelled. So alongside this consultation process, we also piloted 2 screening approaches to try and triangulate and bring together lots of information to help us solve the problem of looking for TBI. So the first thing we did was we looked at whether we could apply an algorithm to clinical notes to highlight possible TBI. So first we looked at consecutive admissions to the Burwood Spinal Unit over a 6-month period. We attempted to track all of the references to TBI in the clinical notes from ambulance records, radiology reports, right through to the rehabilitation notes. And just like the studies in our scoping review, we hit problems locating consistent documentation about TBI. And if the TBI was noted early on in the notes, sometimes this didn't travel with the person as they moved to the new ward or the new hospital. Somehow the TBI information dropped away. So this really means that there is a need for TBI documentation to be improved, especially early on, so that it's recorded. And helpfully in this vein, a large piece of work is underway in our emergency departments on this very issue. And this work is being led by Prof. Alice Steedham from AUT University. So that's going to make a big difference as that unfolds. So the next thing we did, well, we trialled a screening approach with a small number of people at the Burwood Spinal Unit. And the aim here was to see if a screening tool might be an effective and efficient way forward. So after reviewing clinical notes, we looked at self-reported TBI symptoms using a screening tool called the BIST. We used a measure of dizziness called the VOMS. We used a measure of cognitive function called the MOCA, or the Montreal Cognitive Assessment. And we also used a cognitive interviewing approach, and this is where we asked participants to talk through their responses when they were answering TBI questions. And this is an approach that helps us understand thought processes and decision-making as a person answers their questionnaires. And this is one method for improving questionnaires, by getting people to talk out loud about their responses. So what do we find? So when we looked at the clinical notes and looked for multiple indicators of TBI, we found that all of the participants in the pilot met criteria for TBI. Although only 2 participants had a documented TBI diagnosis in their rehab notes. Only 1 person raised a concern that they may have sustained a concussion, but no one had said anything to them about it, so they weren't sure. The rest were absolutely adamant that they had not sustained a TBI. This is an interesting finding and something that was a little bit unexpected. 1 participant had possible TBI-related cognitive difficulties, but it was very minor and mild and difficult to tease out. And there were a range of possible TBI symptoms that were identified, but these were not attributed to TBI, but to other reasons. And so I'm going to show you a table to just show you what people said about these particular TBI symptoms. So take the first symptom, dizziness. 1 person said, yeah, the only time is when they get me up, I sort of feel a bit dizzy, but then it goes away. So I'd say that's just a 1 out of 10. And then a person talking about their memory said, to be honest with you, I think I intentionally forget things because I find a lot of stuff irrelevant. I get a bit overwhelmed as well with everything going on. So I just shut it out. You see, my priority is to get to the gym, get myself strong. So I'll say poor memory is a 1 out of 10. Most of the participants talked about fatigue. One of the participants said, I'll say it's medium, maybe 5 out of 10. That's definitely been more and more, especially energy levels. They haven't been the best, but yeah, being in a chair, not being so active, definitely noticing that I'm getting more tired during the day. There were some comments about sleep, sleep problems being associated to being woken up twice a night for turns, which doesn't help. And then there's this kind of last symptom, this kind of non-specific, I just don't feel right. And one person said, well, it's because I'm out of my comfort zone, like literally because I'm a country boy, born and bred, and here I am, so I'm floundering. So there was really a kind of a sense coming through some of the participants' words that there were some potential or possible TBI symptoms going on, but actually they were really attributing them to other factors associated with their rehabilitation context. So that makes it quite difficult to tease out what's going on. So what are the key takeaways from the SCIPB study? So we certainly kind of identified that from the consultation and pilot studies that these findings completely mirrored the scoping review findings. We've got converging evidence going on here. We're experiencing the same challenges that international spinal cord injury centres are also having. These issues are not unique to the New Zealand context. I'm not sure if that's reassuring or not. But certainly pulling together information from many sources appears to be the most helpful way to capture that TBI. So looking at those early clinical notes, including radiology findings, considering the injury cause and mechanism, using screening tools to raise awareness of possible TBI symptoms, considering other relevant factors, talking to family and whānau is very important, raising awareness that TBI can occur with any level of spinal cord injury or any type of accident significant enough to result in a spinal cord injury. So it's very much a team effort. We also identified through the phases of the SCIPB project that self-report brain injury symptom tools can be confusing to interpret if used on their own. They're just one part of the wider picture. They're still important, I think, in terms of gauging what difficulties the person might be experiencing and flagging possible TBI, but they need to be augmented with other information. So in terms of timing for looking at the TBI, participants in our consultation meetings felt that this needed to be a routine or standard step in the rehabilitation goal-setting phase. And making it routine means that no one feels they have to go out on a limb to advocate for a TBI to be looked at. And that seemed quite an important point to be made. So this step would certainly at that goal-setting phase include checking brain scan findings and early descriptions of injury, looking for references to loss of consciousness or memory loss, and using a TBI symptom screen, including a cognitive assessment. But I'm just coming back to that surprising finding, something that was a little unexpected and not mentioned in any research to date. And that is that there might still be a TBI stigma going on, or some kind of cone of silence or reluctance to accept that traumatic brain injury. So this kind of came through our consultations with people with spinal cord injury that we talked to, as well as being mentioned by some of the spinal clinicians. So this really does mean that more work is needed to normalise TBI assessment as part of routine spinal cord injury rehabilitation steps. So, summing up and concluding comments, quite clearly identifying the double whammy or that dual diagnosis means that spinal cord injury rehabilitation can be better targeted to take into account the impacts of the traumatic brain injury. It's very clear that pulling together and triangulating multiple factors is a standard step at the start of rehabilitation for everyone seems like the best approach after considering a range of perspectives and considering how common that double whammy or dual diagnosis is. So this means TBI is best considered after acute medical concerns have been stabilised. But yet, there may be other barriers we haven't uncovered. For example, quite clearly, there may well be a stigma surrounding having a TBI on top of an already significant injury. So one next step will be to find out more about this and talk to people with spinal cord injury and TBI, find out what their priorities are, thinking about that double whammy and what they think will be helpful. So I really appreciate you listening this evening. I haven't touched on rehabilitation approaches for people with the double whammy or what to do to manage a TBI alongside a spinal cord injury. Our first concern in the SCIP-B study has really been working on ways to much better or more reliably identify that TBI. So to quote one of our clinician participants, it's not missed in the hubbub of rehab. So I'll end it there and we can open up the floor for questions.
Thanks so much, Debbie. That's been really interesting and also really insightful just to see the results that you've got so far. And you can tell it's just, like you said, a pilot study. It's just the tip of the iceberg, and there's a lot more information to find out to actually plan these steps going forward.
Yeah.
But is there a standardized way of caring for people at the moment if they've got that spinal cord injury and TBI both diagnosed?
I think it's very much an individualized approach based on the person's particular situation, their symptoms, their difficulties, the supports they have, etc. But I think one of the points that our spinal teams were making was really around having a standardized step in the pathway where at this point we know that this is when we look for TBI and we use these kind of tools that we have at our disposal, but this is the point that it happens for everyone rather than one person in the team having to advocate or go out on a limb, as I said before, to for the TBI to be looked at. And so, some of the spinal clinicians that we spoke to felt really uncomfortable doing that. They felt like they had to make a case for the TBI to be looked at. So if it's a standard step, it's routine, it's kind of part of the process, maybe that might increase the odds that we're going to pick up TBI, but it also might reduce some of that stigma as well.
Yeah, I guess if you can say to people it's important to find this out now and investigate it so that you have access to the care if you need it going forward, and if your symptoms don't improve, and that might help reduce the stigma.
Yeah. I think that's really important because some of the TBI impacts can last well beyond the spinal cord injury rehabilitation admission and can have a real impact on the person as they're adjusting back to their lives and their communities. And if they haven't had a TBI diagnosis noted down in their notes, it's very hard to kind of access services to help them manage those difficulties later on.
Yeah.
Quite a key point. Yeah.
So now we'll get into some of the submitted questions. And the first one is about the use of upright MRIs in New Zealand and whether they would be any better for the diagnosis of the double whammy.
Oh gosh, that's a really interesting question. I don't know the answer to that question. I don't know, to be honest. I'm not sure how that would make a difference. But that's the limits of my knowledge.
Yeah, well, we fund a lot of research into trying to create MRI pathways that can diagnose the mild TBIs, and I think it's still very challenging to see those on an MRI at the moment.
Yeah,
especially outside of a research setting with the fancy MRIs that they use.
That's true. That's true. And there are a lot of advances in MRI technology, which hopefully will improve the rates that we can capture those TBI impacts. But MRIs are quite stressful for people. We did a study a couple of years ago where we looked at MRIs with people with mild traumatic brain injury, and many of the participants found the MRI pretty challenging. It's noisy, it's clangy, it's claustrophobic making. It's quite a difficult investigation. So any research that shows that there can be those effects can be minimised would be great.
Yeah, definitely. At what point do persistent concussion symptoms become a concern for long-term recovery? So is there a timeline there?
Well, that's another good question, and the timeline is again a really individual thing. But so a majority of people recover pretty quickly over the first weeks and months. First month or within the first 3 months, for instance. And so for some people, though, a smaller number of people that can continue to have symptoms and difficulties out to 6 months or even beyond that. And there is certainly some research even conducted in New Zealand showing that people can still have problems even 1 year to 4 years post-injury in terms of especially getting back into things like work and productivity. So I think anything that extends beyond that 6 month time frame is certainly concerning in terms of the pace of that person's recovery, and would hope that they will be able to access support to promote their recovery at that point.
So would they have missed the window of treatment for rehabilitation, or if you catch the TBI after 6 months, can you still have effective rehabilitation?
Yeah, that again is another really good question. There's never a limited window for rehabilitation. Rehabilitation is always helpful. Obviously, the research supports that getting people into concussion services or TBI rehabilitation earlier rather than later is helpful, and that promotes better outcomes and recovery. But it's never too late to make improvements and expect some recovery with rehabilitation input.
Do you think that part of the stigma around not wanting a TBI diagnosis is people fearing that they'll be moved to mental health services?
I'm sure that that could be part of it. And I kind of think that for a person with a spinal cord injury, that, you know, then to be told that their brain's also gone, not only have they lost their body, but their brain's gone as well, can be quite a confronting kind of a prospect to kind of get their head around and adjust to. So I think for some people it may relate to that. I certainly think that a lot of people with undiagnosed traumatic brain injury kind of worry that they're being seen as if they're going crazy, or they feel like they're going crazy and they're going to get a diagnosis that's a psychiatric diagnosis, and that's very unhelpful. So yeah, I think that stigma is multifaceted, and I think we just need to do some more work on understanding some of those drivers that contribute to that stigma, especially amongst people with spinal cord injury, for sure.
And these days we also hear a lot more about functional neurological disorder, and I think we're getting better at diagnosing that in New Zealand, but can that be mistaken for TBI or vice versa?
Well, I think TBI certainly can be a risk factor for developing a functional neurological presentation. But yeah, it's a tricky question about whether a person might be misdiagnosed with functional neurological disorder when actually all along they had a TBI. I think more commonly people have a concussion, and then that kind of is a risk factor for developing functional neurological disorder, and it kind of flows that way, where that diagnosis follows the concussion after a period of time when that person's symptoms are maybe not recovering, or they're very atypical or not usually seen amongst people with concussion. There's no structural indicators of any damage or impairment, and so the functional neurological diagnosis kind of comes into play. And if this is managed well, and it's the rationale is explained to the person, and then the kind of rationale for treatment can follow, that can be a very positive process. It's not necessarily a negative or a diagnosis of omission. It can be a positive process as well.
Yeah. So the next question is quite interesting. I don't know if you're getting to this yet, but are there learnings from the research that could actually help reduce the risks for people having this double whammy?
Right. Oh gosh, yeah. So that's the kind of the chicken and the egg question, isn't it, really? And it's about kind of you know, all sorts of safety measures around wearing seatbelts and all of those things. Is that kind of where you think that question is coming from? Preventing traumatic?
Yeah, I guess we've got all the things like wearing helmets and wearing seatbelts, and I guess, are there any new insights, any common denominators that could be prevented that are not widely spoken about yet that you've seen?
Well, I think the common educational programs are around protecting the brain when somebody's in activity with high risk for hitting their heads. There's a lot of, I guess, research focusing on things that contact sports people can use and wear, mouth guards and helmets and headgear and things that are increasing in the technological advances that can protect the head and brain from brain injuries and concussions. So they're really positive kind of advances, if that's what you're kind of getting towards.
So the research that's going on in New Zealand, how does it compare to the research in other countries? You mentioned you haven't found much research internationally at all, but how does what we're doing compare?
I think we do really well in New Zealand. For our population, I think we punch above our weight, and the quality of the research that comes out of New Zealand is absolutely at the highest standard. And I'm really proud of what we produce as New Zealanders with our small 5 million people population. But I think what we're also very good at doing is collaborating with other centres around the world. And I think for the spinal cord injury population in particular, the numbers are small. And so really to make any progress, you have to collaborate with other centres, other teams in other countries. Australia, for example, is a really good, we're quite close cousins, of course, with Australians. And so lots of collaboration there. I think that's certainly an important way forward.
Have you found any evidence that there could be barriers of people getting diagnosed with a TBI when they go through ACC?
I think that one of the biggest problems is that the TBI is not documented early on, because that then makes it really difficult for ACC to go back and understand whether a TBI had occurred or not. And, I think down the track, as time goes on, problems get quite complicated and complex. Life gets stressful coping with an injury. And so that stress and those kind of impacts can kind of feed into symptoms and make things difficult for that person. And so it then becomes really difficult for a body or an organisation like ACC to determine, is this just these kind of stress impacts, or was it actually to do with the TBI that we haven't really identified at the beginning? So I think that early identification of the TBI is crucial. And it needs to be documented so that people can access those services later on and not have to have a big fight on their hands to try and prove that they've sustained a TBI.
So if it's properly clinically documented, then people find they do get the correct support from ACC for their TBI.
Well, that's certainly the intention of that early identification. And I think some of the exciting work that Alice Theedham's doing in terms of emergency departments improving the rates of documenting and identifying TBI and getting people into services early is really exciting, and that's going to make a big difference towards giving people access to the right services at the time that they need them.
Yeah, that's really exciting to hear that that's moving into the emergency departments.
Yeah.
So we've got another very interesting question about how criminal justice agencies, so lawyers, corrections, probation, is there any way that they could be better supported to recognise and respond to people living with TBI? I think we hear a lot about TBI in prisons, in prisoners.
We sure do. And I think it again comes back to using screening tools, raising awareness of the high rates of TBI amongst people in prisons and in corrections, having pathways to treatment services. Really similar sort of parallels to what's happening with some of that research in our emergency departments around identifying that TBI, streamlining pathways to services. The same principles apply in the kind of corrections and criminal justice context as well. And just recognising the importance of identifying that TBI and supporting people to have access to services is one of those things that we can be working on.
So if someone has a severe TBI, are there rehabilitation centres like we have for spinal cord injury? And if somebody has both, how do they work out where they go?
Yeah, that's a good question. We certainly do have rehabilitation centres in New Zealand, but they are, again, centralised. So often, just like someone with a spinal cord injury, someone with a severe TBI often has to go to a centre away from their community and their home. So, for example, they might have to go to Wellington or Dunedin or Auckland, for instance, to access that rehabilitation. And that's really tricky, being away from the supports and being away from your community. It's the same issue for people with spinal cord injury with just those two rehabilitation centres in New Zealand. So people are often a long way from home. It's hard for families to be there to support their family member while they're in hospital rehabilitating. And often those rehabilitation admissions can be many weeks. So that's quite a stressful scenario for a person to be alone and away from family and supports. So yeah, that is certainly a big issue. But there are, across the centres in New Zealand, there are also access to outpatient and community-based services that people can be referred to through. These are generally funded by ACC, concussion services and other kind of support services for people with TBI. So that means that people can access those services in their own communities. But when they're in hospital in that kind of inpatient phase, it's much more challenging.
Yeah. And let's say someone was watching this webinar tonight, and they've previously had a spinal cord injury, or maybe they're still recovering from that, and they've realized that maybe they've actually had a TBI, but it's, you know, been years, say. Is it still worth getting that dealt with if they've got ongoing symptoms that they're now recognizing was a TBI?
Certainly, if they think that they've got symptoms that they think could be TBI related, they should definitely go and talk to their GP and maybe have that looked at. As time goes on, it becomes more and more difficult to kind of be really clear that some of the difficulties that they're experiencing could be attributed to that injury such a long time ago. But that's it's a very individual thing, and so that shouldn't put somebody off going forward and seeking assistance and making that determination about whether these symptoms that they're experiencing are still attributable to that brain injury or not. It's still really important to ask that question.
And how do you think things like sleep and nutrition can help influence recovery from TBIs?
Yeah, I think they're really important. And we often see in our concussion services that people will come along and they're really having trouble sleeping, and often those sleep difficulties are underpinning everything they're experiencing. Everything is so much worse because they're not sleeping well, and they're waking up already tired before they even start their day. And then on top of that, they've got that neurological fatigue associated with the concussion or the traumatic brain injury. So it's another form of a double whammy, really, in a way. And so certainly eating well and working on sleep can make a huge difference to recovery. It's a really important part of some of the work that the concussion services do.
So there's been a lot of chat in the chat tonight, and people have been really engaged in your talk, which is awesome, and some really nice comments about you presenting really clearly and everybody learning a lot. So
Lovely.
I just want to say thank you for that, but we will end on a different sort of question, which is what kind of impact could increased support for research have in this field?
Right. I think it could have a huge impact. And again, you know, I think supporting researchers to collaborate with larger teams, especially, would make a huge impact in terms of outcomes. And I think supporting clinicians to get involved in research and people with lived experience to get involved in that research kind of really improves the relevance of that research, and really can result in some improved outcomes for those people living with those conditions. It's really hard out there at the moment finding funds for research, health research, and so I think that's a big challenge that we're facing as a small country with a small health research funding budget relative to other countries. So I think that is a big challenge for us.
Yeah, we've noticed an increased number of applications coming to us as well. So there's no shortage of great research going on out there, and it's really hard to decide how to fund just some of it. But we do really wish you all the best with the exciting research that you're doing, and also the things that you've mentioned that are going on with the wider team, and Alice implementing screening tools in the emergency departments. And we look forward to having you back in the future at some stage with some updates on how this is all going. So I just really want to say thank you for taking the time out of your busy schedule to talk to us tonight. And also want to just say thank you to everyone for joining us tonight in our webinar. And we hope that you've learned a lot. And if it was a lot of information to take in, you can watch it again when it is when the recording is put online.
Well, thanks so much, Sarah, and thanks everyone for listening and putting up with me. I really appreciated it.